I'll give you a general idea about the procedures, the indications. This is my conflict of interest. I have no conflict of interest related to this. I'm a speaker to Novartis and Amgen, and thanks for Medtronic and Record for supplying us some of the educational materials. So jumping into the topic, all of us know that hypertension is the main cause of global burden. Almost 1.4 billion people are suffering from hypertension. 1/3 of the adults have hypertension. So it's a real burden on the health, the economy of the health. 50% of the people that have hypertension have uncontrolled hypertension, and 15% of them have resistant hypertension. And we are not doing really good because over years we are not improving the control of blood pressure. Almost 50% of the people that have high blood pressure are not being controlled. Again, 50% of the people will stop their medication after a year. And all of this might look not a big deal, but when we look at this slide, we understand that a minimal reduction of the blood pressure is extremely important and decrease the major cardiovascular disease, stroke, heart failure, ischemic heart disease, and cardiovascular death. So there is about 10% relative risk reduction, decreasing the blood pressure only 5 millimeter mercury, and about 20% relative risk reduction if we decrease the blood pressure about 10%. And I think this is very important to understand because the expectation from renal denervation should be also reasonable. So the goal was, if we are not doing well with medications all of these years, we probably can look into something else that would help the patient having a better control over the blood pressure, and that was the renal denervation. Basically, what you are trying to do is, when I interrupt the neurohormonal process, basically, by cutting the renal sympathetic nerves. Basically, you are cutting the afferent and efferent effect, which is important to interrupt the RAS system. So this is a very busy slide, but it's a very important slide because it's kind of an update recently by the European Society of Cardiology in 2023 and the American College of Cardiology and the American Heart Association in 2025. They issued a consensus paper. It's not a guideline, but it's a very important paper. Both of the ACC and ESC give renal denervation a class 2B indication, which is, I think it's a progress from what we used to have. And both of them would agree for one of the three indications for the patient to undergo denervation. Basically, uncontrolled resistant hypertension, intolerant to medications, even if the patient, if he's only taking one medication and this is the only thing he can tolerate, but his blood pressure is not at goal, that's acceptable to consider the procedure for the patient. Or high cardiovascular risk, basically people with a stroke, people with intracranial bleed in the past, these are people you can consider doing the procedure, even if the patient is relatively well controlled on medications. So why do we have the idea of renal denervation back again into the horizon? Because we have a better understanding of the concept of renal denervation recently. What we used to think was this upper picture here. We thought that the proximal and the distal nerves are all at the same level, which is not the truth. And if you don't understand this concept, your treatment is not going to be effective. So basically, the way that the renal nerves originate from the wall of the aorta is coming in like a cone shape. So they are a little bit distant from the wall of the renal artery proximally. And the more distal you go, the more it gets closer to you. Which means that if you are going to denervate the main renal artery shortly after the ostium, you need to have something that has a good penetration. If you are more distal, you don't have to have the highest penetration. That's the first fact out of this picture. The second fact is most of the renal arteries are, the renal nerves are actually more distal than proximal. So if you treat the proximal segment only, which is acceptable with the ultrasound-guided treatment, the dilemma is you might not get a full control over the blood pressure because you didn't denervate distally, you didn't denervate most of the nerves actually. And this is a cut section that will show you the distribution of the nerves and how they cone into the renal artery more distally. So that's why if you are in the proximal segment here, the renal nerve is going to be a little bit deep for you to be able to achieve it. So in the next few slides, I'm going to take you through two things. Number one, the procedure flow very quickly, the idea of the procedure. We will talk about the two technologies that we have and the data behind that. So first thing you need to do is you either have a CT angiography already, but either way, I would suggest that you get an angiogram. From this angiogram, you need to assess the renal artery, if there is an accessory artery, how far you're going to go with a renal denervation. You do not go into the renal parenchyma. So you have to assess if the patient has FMD, fibromuscular dysplasia, if he has an aneurysm. All of these theoretically are contraindication to do the procedure. And there are two major technologies, the radiofrequency and the ultrasound-based system. Most commonly used of the radiofrequency is the Medtronic one. I think this is the one available in Egypt. But there is an ultrasound-based system by Record, the Paradise system. There's another company, I think it's called the Stellar, that's the Netrod procedure. It's a radiofrequency also, but I don't think it's available here. So I'm going to be talking about Medtronic very quickly. I'm not paid by any of them, but these are the two big devices in the market. So basically, this device has a loop not a loop, like an S-curve kind of, so that it can stretch and recoil basically. So it can cover from 3 millimeter to 8 millimeter. This was the most studied. The Medtronic is actually they have credit because when everybody says renal denervation is not going to work, because they continue to publish their data. So they had a lot of data and much higher than their competitor as a number. It's one catheter that fits all because of the shape of the catheter. It can take different diameters. Again, what you want to make sure is you try to ablate the main artery, the accessory artery, the big branch around 3 millimeter at least. You don't want to go into the parenchyma for sure. So the Medtronic one has 4 emitters on it that emit radio frequencies. The good part about that is you can get an impedance from each emitter, so you know if you have a good contact with the wall or not. The other thing is you can disconnect one of the emitters. So if you think you are at the carina or you are too deep or too proximal, you can just turn off channel 1 and you can use 2, 3, 4. Basically, that's what you want to see. There are no fixed numbers, but that's what you want to see. You want to see a decrease in the impedance of the emitter and an increase in the heat. If you are seeing that would stabilize after very few seconds, you are in the right path. The ultrasound is a balloon guided, basically. They did also multiple trials. The trial was around 130 to 140 patients. The other ones were in the horizon of 300 to 400. So, but each of them have a registry in around 3,000 patients, and both of them have strong data. This is the important part I want to show here. In average, just to put expectation for everybody, in average, the blood pressure will decrease about 9 to 10 millimeter mercury in the first year, using whatever company you're going to use, whatever device you're going to use. So basically, this emits an ultrasonic wave. You first inflate a balloon. The balloon has a hydrocooling, so it cools the first 1 millimeter. So basically, it tries to protect the intima. Then you emit an ultrasonic wave that regenerate heat, basically, and ablate the nerve. This is one of the last slides here. When do you use each of them? I'm not sure that the Record is available. I asked somebody yesterday if it's available in Egypt. I don't think it is yet. But I think they are complementary to each other. They cannot replace each other. I think the ultrasound guided is better if you have a straight artery, a big artery. You don't have to go deep. The radio frequency by Medtronic, it's better when you go deep into branching vessels. And if you have a very short main renal artery and early bifurcation, because if it early bifurcate and it's short, that's an indicator that the nerves are more distally because they are on top of the arteries there. That's what I mentioned. Basically, the future is we have to have a better selection of the patients. There is something going on now. It's called the liver denervation. It's being in process, actually, and one of my colleagues in Cleveland Clinic has been working on that. It challenges the cost effectiveness. Nobody pays for it. I mean, currently I practice in Dubai, and I think that we have one insurance company that would pay for it. So it's not being paid, and it's not cheap. So that's my conclusion. It's an evolving technology. I think it's going into the right way. We are not completely there yet, but I think we are having some good progress. We have stronger evidence now, higher number of patients, better endpoints, and this would be something of personalized medical care of patients to have different technologies that would serve them. With this, I conclude, and I'll be happy to take